to Second Opinion, a new show from the Los Angeles Times focusing on health, science, and technology. I'm Eli Stokols. I'm a White House reporter at the LA Times Washington Bureau, back with you to moderate another important discussion about the coronavirus pandemic. Dr. Patrick Soon-Shiong is the executive chairman of the Los Angeles Times. He's also a surgeon and scientist who has spent his career studying the human immune system in order to fight cancer and infectious disease. Dr. Soon-Shiong is the chairman and CEO of the biotech company NantWorks and the owner or investor in other companies researching treatments for COVID-19. And we're joined again by William Haseltine, a noted biologist and former professor at Harvard's Medical School and School of Public Health. Professor Haseltine is known for his groundbreaking research on cancer and HIV/AIDS. He is the founder and CEO of biotech companies responsible for drugs treating cancer, HIV, and AIDS, and is the chair and president of a nonprofit think tank called Access Health. Professor Haseltine is also an author. His most recent books are A COVID Back to School Guide and A Family Guide to COVID, Questions and Answers for Parents, Grandparents, and Children. Dr. Soon-Shiong and Professor Haseltine, welcome back. Dr. Soon-Shiong, in our last episode, we discussed the resurgence this summer of COVID-19 and the high stakes when it comes to public health. In this episode, you'd like to talk about what it will take to begin to get this outbreak under control in the U.S.
Absolutely. I think, what's really frustrating and concerning. So if you look at the results today, in the last 11 days, 1,000 deaths per day. Think about that. In this country, we have 1,000 deaths per day, and today in South Korea, there's 1 death. So we've got to be smarter than this. We are better than this. And we have a way to outsmart this virus. We have all the technologies to outsmart this virus. If we think about this virus as a cancer, and if you think about the crazy idea that if you could give your family member cancer by breathing on them, you would do something differently. And in a sense, that's a way to think about this, that this is a race against time. And it's about time, rapidity, and the ability to stop it. If you think that this virus is like a cancer and you could give cancer to your fellow man by breathing on them, and that in fact that the virus has taken over your body as an incubator, you are the host. And if you think about that, the purpose of this episode is to try and explain the science behind this coronavirus, but in a factual way that we have the ability to change it. We have the ability to stop it. We have to, we must. 1,000 deaths per day is unacceptable. This contagion has an ability for us to actually go after it. And the way to think about it is we have to test, but we understand the rapidity of the test is more important than anything else. Then we have to identify that person that is positive, and most importantly, we have to isolate that person. And if we can actually do that and explain to the leadership of the country, explain to the state, the federal, and the county at every level, that if we can test, get the results rapidly, and we'll explain a little bit more, and then contact trace, and most importantly, isolate, and then stop the burn. If we can stop the burn, meaning stop yourself as the factory, we can burn out this virus and stop the 1,000 deaths per day. We really have to get there now because time is of the essence. And that's the purpose of today's show.
Professor Haseltine, do you want to pick up on that thread for us?
I think that summarizes a lot of what we're going to discuss today and what we can do right now with the tools that are in our hands to stop it. One of the most insidious aspects of this infection is the fact that it can creep silently into your house, can creep silently into your body. Think of it as a very stealthy burglar who can come in at night, you don't know he's there, and by the time you realize the damage is done, it's already too late. So we know this virus gets into you, and for 2 or 3 days, you are producing a lot of virus. A lot of virus that can jump from you to the person next to you in droplets. If you breathe it out, it can last in the air in small, tiny droplets called aerosols in a closed space for many hours. Somebody else comes into that space, they breathe it in, it gets into their eyes, they touch a surface with a droplet, they'll get infected. And it does something else that we're learning about now. As it comes in, it turns off the alarm system. It actually turns off the early part of your immune response. That is a pretty dangerous thing for it to do. And it gives it a free pass for a few days before the rest of your immune system can come and try to shut it down. And by that time, if you're not lucky, it's starting to cause very serious damage. The thing that we have to do to try to control the epidemic is we have to find those people who are spreading the virus early. That means you don't test the worried, you don't test the mildly ill, you test a very broad number of people. And to do that, we're going to talk about the kind of tests that can do that.
Professor Haseltine, Dr. Soon-Shiong, thank you for getting us started. Fascinating stuff, and we look forward to getting into those topics more in depth in just a moment. But first, we're going to spend some time looking at how the coronavirus has made an impact in one particular part of California, Imperial County, just north of the U.S.-Mexico border and east of San Diego. A recent Los Angeles Times piece took us there. Its headline, "Hardship Piled on Hardship." There are about 180,000 people living in Imperial County. Compare that to the 10 million people in LA County, and you get a sense in the difference in scale. But per capita, Imperial County's infection rates are notably high, and the death rate from coronavirus has led the state. The county's 2 hospitals, the LA Times article reports, became so overwhelmed by the surge of cases that they were forced to move more than 500 patients to other California hospitals. When El Centro Regional Medical Center ran out of ICU beds, Chief Executive Adolphe Edwards said, "It's horrible. I feel helpless." We have as our guest the hospital director whose quote you just heard. Dr. Adolphe Edwards is the Chief Executive of El Centro County Regional Medical Center, one of the 2 hospitals in Imperial County. Dr. Edwards, thank you so much for joining us. I want to begin by asking about the problem that you articulated in our report. As a hospital administrator, I'm sure the last thing you want to do is send patients away, especially now. But does the sheer space for patients continue to be a problem at your hospital and in the county general?
Thank you very much for having me. We've seen a slowdown of the total numbers in the last just a couple of weeks, which is a good news story for us. We're able to breathe a little bit of a sigh of relief for now. But we shouldn't be resting on our laurels because we do anticipate that probably going into September and October and into probably February of next year, those numbers are going to climb back up again. And frankly speaking, from a perspective of a health system administrator, the last thing you want to do is exactly what you're saying, is sending any patients away from their home community. One thing I wanted to add, if I may, is that our number of 180,000 is actually a misrepresentation because we have an OPEC border, meaning we're very close to Mexicali, and we see there's 278,000 U.S. citizens that go back and forth. A lot of them have actually residency here on this side. So we think the 180,000 is a misrepresentation of the total population we have.
I know there's never a normal or an average day in a hospital, especially during a pandemic, but can you give us a sense, just sort of an average day, or as best you can describe it, in this situation in your hospital as you're coping with this, especially as cases have surged in your county?
Sure. So if you can imagine a 20-bay emergency room department that is receiving anywhere from 125 to 150 patients daily. Nonstop work. ICUs, our 12 ICU beds were not sufficient. We actually increased our ICU capability up to 30 beds, and it wasn't sufficient. We've added not 2, but 4 Alaskan shelter tents, one of which is used to increase our bed capacity by 15 beds. So, of course, our staff needed to be actually increased as well. But when you're seeing 65 plus patients that are COVID positive, for a 160-bed hospital, that's a very high number of COVID positive patients. And not only that, we are a part of the University of California, San Diego. I am actually a UCSD employee. And as part of that, I had to rely on their ECMO or extracorporeal membrane oxygenation team to come in and care for morbidly obese patients that have high rates of asthma and diabetes, complications beyond complications. So these are not your average patients. And now that puts a lot of stress on the facility here.
And you're leading me to my next question, Dr. Edward, which is about the public health picture in Imperial County more generally. There are, it seems, so many factors predating this pandemic that have made this more lethal there. Can you talk about some of the conditions and the things that people living in this county face that make them more susceptible to COVID-19?
Absolutely. One of the first things that we did about 4 or 5 years ago is actually go after some grants to try to help us. I saw the rates of diabetes, asthma, COPD, and I can keep going on and on. Our rates of cancer have increased and are continuing to rise. The community is poor, so poverty adds to the problem of the disease prevalence in the community. We have the highest numbers of unemployment. Now we're in 34% plus. So this COVID just kind of shined a light on a lot of things that we need to try to change for communities like ours here across not just the California border, but you probably can take this discussion into Arizona and Texas, just to name a few other states.
You know, it is such a dismal situation, but I wonder if there is perhaps a bright spot that you can share. The heroism of the people on the front lines of this is a subject that I don't think gets enough attention and coverage. But can you help us wrap this segment on maybe a more uplifting note? Is there something that jumps out at you?
Yeah, absolutely. The resilience of the staff here, because they come from this community. Their mothers, their fathers, their brothers, their sisters are from this community. They wanted to stand up and actually fight the war against COVID, but they needed the resources. And I'm very thankful for Senator Feinstein and others that have actually stepped up and supported us by providing us the needed resources. The community here is relying on our sons and daughters, which is the people working in the hospital, to actually push us through this. So I am thankful for the resiliency. I think we're going to get through this because this is the United States and we're going to be able to actually push through it or fight the good war. But I think we need to continue to invest in the infrastructures. We're not going to abort our mission. We're not going to leave anybody behind, and we're going to continue to fight. And I'll be the first to raise my hand and ask for more resources if that's what's needed. So war on, and we're going to win it.
Well, Dr. Edward, thank you for the work you're doing and for joining us. Please stick around. We're going to bring in now the Los Angeles Times' Ruben Vives, the staff writer who reported that story on Imperial County, and Irfan Khan, the LA Times staff photographer who took the photographs accompanying that piece. Ruben, I'll start with you. Your piece exposes just how much this pandemic affects disproportionately people who are poor, who can't stay and work from home. What did you find out when you were talking with these families and these individuals specifically about the situations that they found themselves in with either poverty or joblessness? What did you learn as far as just how much these existing factors are exacerbated and leave people so much more vulnerable to this virus?
Yeah, you know, Imperial County is the population there is poor. A lot of people live together, so the infections are spreading within the households. So when one person gets infected, you're just infecting several others. In addition to that, you're having a high unemployment rate. While we were talking to folks, we found out that there was a long line of people just trying to file for unemployment. On top of that, there were folks who were standing in line. There was not many banks around the border there. And so many people were waiting up to 2 hours just to pull out money from an ATM machine. And that's money that they are going to use for rent. And these are all people who are unemployed. I think at that one day that we were there, we counted more than 100 people. So the level of hardship there is just could be felt from different angles, from economic to environmental issues. The Salton Sea is nearby there. It's where you're getting a lot of toxic dust. It's adding to the long existing problems of that region.
Irfan Khan, your photos really helped tell this story, including the very moving story of the Luera family, an older couple who were among the hundreds of patients that had to be airlifted out of Imperial County. Tell us a bit about your experience documenting what was going on there.
While searching for the patients who were airlifted from Imperial Valley, we found that in some cases, patients from same family were separated and sent to different hospitals, some as far as Sacramento and Santa Barbara. When I approached Paradise Valley Hospital in San Diego County, I found out that they have accepted two patients. It's a couple, Mr. and Mrs. Luera. They were airlifted from El Centro. We decided to follow this couple, and going through different permissions and all those things, we contacted the family. And one thing I found out while in the hospital, the nurses were so kind. You know, the nurses comforted Mr. Luera by telling him that his wife is right in next room. That's amazing there, you know, to see these nurses and healthcare workers are doing such a heroic job.
You are obviously right there in the room, and these are rooms that even loved ones, because of the virus, are not typically able to be in to comfort their loved ones. And you're taking these photos, obviously, at some risk to yourself as well. Can you just talk a little about your preparations for going into this hospital and why it's worth it to you to get these images and to bring these to LA Times readers?
As I was coming out of the room, patient's room, nurse stopped me. She told me, death by coronavirus is the loneliest death. When patients die alone, there is no family to comfort them, no one to stand by them. It's truly a lonely death. And as far as the risk I'm taking, we have to take some risk, you know. Thankfully, we are working for a company that provided us some very good protective protection gear. I was pretty well trained by some doctors from my previous assignment how to protect myself, but still there was some worry and scare because I know that I have to go back to the family and I don't want to carry this. This virus is very deadly. This enemy is invisible. You don't know when and where it is going to attack you.
Well, it's important. I mean, death on this scale is something this country hasn't seen in over a century, if ever. And part of the reason that it's hard for people to grasp is that it's so abstract. People are not up close to it. There aren't images of it all that common. And so to have your pictures is really an important thing. And we thank you for your work. Ruben Vivas and Irfan Khan, we thank both of you for joining us and for this story. And also Dr. Adolphe Edward, Chief Executive of the El Centro Regional Medical Center. Thank you too for joining us. We're going to turn now to the central question in this episode. How do we begin to get a handle on turning back this pandemic and controlling the contagion inside this country? Dr. Soon-Shiong and Professor Haseltine, I know you've been thinking a lot about this question, and we'll get into it in a bit more depth now. Dr. Soon-Shiong, let's begin with a number of steps that need to be considered and considered in a certain order according to your thinking.
I think, as you just said, Eli, it's abstract to people. And maybe what I should do is try and draw on the board and try and make it less abstract. I'll try and create a diagram that talks about, on the one hand, the one axis, the viral load, meaning this is what you as a human being is acting as the carrier on behalf of this virus. This treacherous virus has figured out how to use you as the factory. On the other hand, you have time. And the time is day 0. And you go all the way to 3 weeks, day 21. But there's a critical period of time within the first 3 days, and then 7 days, and then 14 days, and then 21 days. And this is what happens, we believe, with the viral load. And clearly, as I said, it's a silent entry into your body on day 1 or day 0. And then the viral load starts increasing. And as it increases, and then over time, your body can clear it. But this is the issue that we worry about. It is this time, from this time to the first 3 days, let's say, where you may be asymptomatic. So this is when you become the spreader. So it is this time frame in which the virus load is in your body, and you can now actually infect your family. So as I said, imagine that in this 3 days in which you have this load and it is silent, and you now become this literally this bomb that you're carrying and you're spreading. It is during this time that we need to catch this person and reduce the ability for this person to spread. So this is what Bill and I are going to talk about today is how do we do this? How do we catch this time period? So it's a combination of a viral load and time. And time is probably more important than the viral load, because unless you catch this person then infects all the other people, and then that perpetuates into another viral load. So it is so important for us to take this out of the abstract, that not only do we need to do the test, we need to get the results back quickly. Ideally, you could get the results back in the first day, within first hour and first minute, but you can't. But you can get the results back so that before this person goes out and spreads. What is amazing, this technology exists. This technology now exists. This test to catch this person exists. And so that you can isolate this person so that you could burn out this virus. This person burns out the virus, and that's how we get this pandemic or this contagion stopped. That's what's happened in Korea. That's what's happened in New York. But we need to do this across the entire nation. So we'll get into the testing of how this happens, but I'm trying to take out the abstractness of the testing. The purpose of the testing is to isolate and identify this person that's generating this viral load and is basically becoming the contagion. And so if we can stop that, we can actually find a way to stop this contagion.
Well, I come from the AIDS wars, and I was one of the very first people to do AIDS research, sequence the virus. And there's a lot of similarities that I'd like to point out. One of them is there's a long silent phase of HIV. People get infected, and it's not a matter of days, it's a matter of years. People with HIV can be infected and can spread the virus through one means or another, through blood or through sex or other ways, mostly blood or sex. Mothers can give it to babies. But it's a long phase, maybe 7 years. And we very quickly, after the virus was isolated, very quickly developed tests. But there was great resistance to taking the test in those days because to be identified was a death sentence. I was actually involved in some of the early tests. I developed a test very similar to one that we're going to discuss in just a minute, a rapid test. It was a test I wanted to have people use at home. It took 25 years for the FDA to approve it. 25 years. They thought they needed to control all the information. That's a lesson I want to apply here. So what are we talking about? We're talking about tests that you walk in, you get the test, and before you walk out, you have the result. That's what Patrick and I are talking about. Because once you do that, you have the person in your hands. Is that imaginary? No. It's being done today in, of all places, India. We need to mobilize the resources, just like we're doing for the vaccine. We're spending over $10 billion giving it to companies that each have $50-60 billion a year of sales. We're handing over billions of dollars and say, please make a vaccine fast for us. That's not stopping this epidemic. That's not stopping people dying today. We should be doing much more right now to stop this epidemic.
Well, there sure is a lot of anecdotal evidence from folks around the country who have gone in for tests that it's not coming back quickly, that sometimes it's taking more than a week, sometimes close to 2 weeks. One of the things that was really interesting to me is that relationship between what's called the viral load and incubation period within a person who has the virus. And also the fact that there are different tests that are more useful at different times. A lot of people are not aware that there are differences between the sorts of tests that are out there and that they're designed to show different things. So Dr. Soon-Shiong, let's take a hypothetical case. You've been exposed perhaps, and you think you're infected. What would you do in that situation? What kind of test should that patient take?
I think Bill and I both feel very strongly that if you're out there in the community, you may as well believe you're infected and not wait for the symptoms, because a huge amount of people are asymptomatic and are infected. So the big question is, are you a spreader? And in a way, you need to bring this out of the abstract. Are you a danger to your family and friends? And I think that's how we need to couch this question. Because of this ubiquitous nature of this virus, where it comes in and it actually, for whatever reason, doesn't generate symptoms, this is the greatest fear, and that's why this is a race against time. So the whole point of the question is not you think you've been exposed, you need to think, should I be isolated? And the only way we can actually come to this in a pragmatic way is to have a test that is rapid and relatively accurate to give you this insight that are you the spreader. So you hear about tests about antibodies, etc., and PCR tests and an antigen test, and it's confusing. So I'd like to take this opportunity to first address how you think about tests. So if I could have a clean board here and try and describe what we're trying to test and why. So the best way to think about this virus, I'll just draw it, it's a piece of RNA, which is in the world of science, the genome with a spike on the outside, which acts as a syringe and gets into your cells. So there's this test that actually measures the RNA itself, i.e. the virus. So it's measuring what we call as the genome. And that's the test that everybody hears about, the PCR test. And while the advantage of this is very accurate, the disadvantages of this, there's a shortage of supply because you need to extract the virus and break it down into its little pieces and then amplify. And that's the whole point about this amplification that makes it accurate, but it gives you a result, unfortunately today, in 7 days. Now that is useless if, remember, you talk about day 0 and you become infected by day 3 and you're asymptomatic and the virus is doing that, let's say. And now you're infected, but by day 7, you've infected hundreds, maybe tens of people, which means you need another rapid test. So there's a way of actually doing it where people will just take a little piece of this, a little piece of that, a little piece of that, and that's called an antigen test, and I'll give you a different color. And that's what Bill's referring to, that's being done in India. It may be less accurate, but it's faster. You get the result faster. What is more exciting to me now, however, there's a new test that has just been launched, just been developed, that can measure this RNA in a new test which is called the LAMP test. And it measures this RNA without having to do this extraction, without having to, and it's just a color. And you can quite literally get the results maybe in 30 to 40 minutes, like a pregnancy test. It may not be 100% as accurate as that, but it meets the criteria of getting this within 3 days. I'm completely disclosing that our organization has also worked on the LAMP test, and we're going one step further, calling it a Q-LAMP test, where you will not only take it from a color, but quantifying it and bring it in so that within 24 hours you can get this result. So this is a revolution, I believe, of measuring the virus, in which even if it's positive, you know then that you're a spreader and you must isolate. If it's negative, you take the test the next day and the next day. However, if it's negative, you can then have the luxury of then continuing this more accurate test to make sure it is truly negative. So the danger of this LAMP test is a false negative. But if you do it enough times and you have the time then to do this detailed PCR test, I think this is the way between either the LAMP test or the antigen test. If you think you're exposed, I believe we can stop this pandemic by executing on either the LAMP test, the Q-LAMP test, or the antigen test, ensuring isolating the positives, and we reduce the spread by 80%. That's the number, that's the projection. In those that are negative, you come back the next day, you get the test again, and or you do the more detailed PCR test. So that's my recommendation for somebody who thinks has been exposed, who've been out in the community, and are now coming back to their family and friends. This is what I think we should be doing. And in fact, what's exciting, this is how we can maybe open up schools, sports stadiums, where people then will be able to get tested before they enter into this gathering. So I hope this explains a little bit the test. When you think you've been exposed, we can measure now the virus itself, on the one hand in red, or you can measure the piece of the protein of the virus called the antigen test.
It's really interesting stuff, Dr. Soon-Shiong. Before you sit down, I want to ask you about another scenario, maybe slightly less urgent, but for someone who thinks that they may have already had this virus, maybe their symptoms were mild, and they'd like to be certain, what kind of test would they take?
So this is a different question, and this is where you think you've been infected before, and the question now is now a test of immunity rather than a test of infection. So that's why I think it's so you have to be very clear of what the question you're asking and why you're asking this question. So you've had an infection, you've actually been tested positive for COVID, you've lost your taste and smell, and you were at home and you figure out that you must have had COVID. So the question is, am I immune? So then the question is, how would you know if you're immune? Well, unfortunately, scientifically, we don't have the full answer, but at least we are now learning for the first time what I call the pathophysiology, pathogenesis of this virus. There's two ways in which you would generate immunity. On the one hand, you would create what we call antibodies. And these antibodies would block the virus right there, block the entry. On the other hand, you'd create T cells, and the T cells would kill the factory that makes the virus. So the way to think about immunity, there's two types. One in which you block the entry. The other one is where you just clean up the house, where you clean out the factory so you can't make more of this virus. Well, so there is then therefore an antibody test, and the other one is a T cell test. The tests that's on the market out there are these antibody tests, and the problem for us at this point is that these antibodies are now been found when you are infected, that within 3 weeks to 4 weeks to 6 weeks, these antibodies wane. Now, what does that mean? Does it mean you're no longer immune? We don't know that, because we don't know, are there memory cells that will bring back the antibodies? But what I am 100% convinced about now, as I'm beginning to see the science, is that these T cells, if you have T cells, these T cells have now generated 17-year length immunity. Not in the sense of immunity that these T cells will remember and will kill the factories. These are specific T cells that recognize COVID. So the key is that these memory T cells. So the two tests that are with regard to immunity, one is the antibody test and the other one is the T cell test. How long will my immunity last? I don't think we know that answer at this point. The history about coronaviruses are that they don't, because of the antibodies wane. And this virus has figured out a way to suppress your immune system, like cancer. There is a protein in this virus, which has now been shown, called the N protein, which is really the predominant protein that drives T cells. And I believe this knowledge, or this science, that has now taught us that is T cells is the importance, as well as in antibodies, that we need to develop a vaccine that drives T cells. So the question is, if I've been infected before, this is a common test. This is not so common test out there, but this test is available to see if you have memory T cells. So in our laboratory, we have taken patients who are infected. We've taken their blood, and they call their serum, and we've measured the antibodies, and indeed there are antibodies called neutralizing antibodies that block the activity of this spike protein. But excitingly, we've also then activated their T cells and found specific T cells that actually recognize N. So these tests are now available where you can measure both antibodies and T cells.
One last category, Dr. Soon-Shiong. Obviously, there's so much anticipation about vaccines, and we are at least a few months away. Will there be tests to determine whether or not those vaccines work?
Well, when you get infected, you quasi-vaccinated theoretically. So if you're infected by a virus, the COVID virus, you're infected and it has a spike protein. It has a thing called RBD, which is actually the tip of the spear that goes into your body. It has then the N protein. So the vaccines today that's in development are these spike proteins in which they will create antibodies, and that's just like the test we talked about. And the purpose of these antibodies is to prevent or block the spike protein from entering into your body, acting like a blocker of this injection. So if we take a vaccine, how will you know it'll work? Then you need to see whether you have antibodies that are neutralizing. The unknown question is how much, how long? How long will these antibodies last? How much antibodies you need to neutralize? So this is most of the vaccines that are in phase 2 and phase 3. All of them are taken on the strategy of trying to teach your body to create antibodies against spike. In so doing, it also does create some T cells, but that's not the predominant focus of this vaccine. I believe, again, that you need a vaccine that not only takes on spike, but takes on spike plus the N, so that you can go generate the T cells as an active motion. And if you had both, then I think you'd have the best chance. Now, this is the immune system inside your body, your blood, your spleen, but it's not in your mucosa. And this is where the virus comes, in your nose, your mouth, your guts. So you need yet another antibody called IgA, or called mucosal immunity. And the best way to get that kind of protection is have the vaccine either in your nose, under your tongue, or in your guts. That'll give you mucosal immunity. So this is a complex story, very much like cancer, where on the one hand you need mucosal immunity, you need T cell immunity, and you need antibody immunity. I think it's the only way we're going to beat this virus. Treat it like cancer. Identify all its weak points at its neutralization point, at its T cell point, and its mucosal point.
Okay, Dr. Haseltine, I want to get your input now. You've written about just how critical testing is and how the developments in technology that Dr. Soon-Shiong just spoke about may improve some of the flaws in our systems. And I also know you really feel an urgency here, given the effect that this pandemic is having on the entire country, especially on communities of color, poorer communities. Can you talk about how vital this is and where we may be in solving some of our testing problems and getting up to speed a bit more?
Well, we heard earlier in the program the impact in that community, but that's only one of the many communities around our country that's being similarly impacted. The foundation that I've created about 15 years ago works on health inequities around the world. But much to my surprise, some of the greatest health inequities we found were here in the United States. Let me just give you an idea of the magnitude of those inequities. If you compare the United States lifespan, maternal mortality, infant mortality, death under the age of 5, death under the age of 20, we perform much, much worse than other high-income countries. How much worse? We're 2 standard deviations below the means. We're at number 34. There are 34 countries in the world that have much better health outcomes than we do. We're down there with Dominican Republic, a tiny little country with limited resources. That's our health outcomes, not because the middle class or the wealthy don't enjoy very healthy, long lives. It's because big parts of our communities are not well served. Let me just give you an example. Here in New York, if you go to the Bronx, you go to where there's Black and Latino communities, you will find the infection rates for COVID and the death rates are 6 to 7 times higher than they are in Manhattan and other parts of the city. That's really shocking. If you're in Chicago and you go every 2 or 3 blocks west, you lose life expectancy. That's not because we don't spend money on healthcare. We spend twice as much as anybody else and get number 34 rank in the world. That's a disgrace. And what you see with COVID is exactly that. And that's what you were hearing from those people who are fighting day and night to save their relatives, to save the people they love and grew up with from this epidemic. Is there something we can do right away to stop this tragedy throughout this country? And the answer, I think you've heard from Patrick and me today, is absolutely yes. We can, with technologies that are here and now and approved for emergency use authorization by the FDA, immediately address identifying those people that Patrick called the spreaders. Those are people who are infected and don't even know it. The 90% of people who are infected and don't even know it. For that, you need a rapid, fast, cheap test. Those are available, but we're not deploying our resources. Now, I've been a good friend of Dr. Fauci's. I've worked very closely with the National Institutes of Health. They're doing everything they can to develop those tests and give the money to develop even new tests, which, as you've heard from Patrick, are around. But I don't see any effort to speed that along and put them into people's hands. Now, I've just written a book called A COVID Guide to Back to School. And I give advice. The only advice I can give right now is to know what your risk is. Know who's around you that might be infected and might infect your child. Know the susceptibility that you have in your child if you're particularly infectable or will get sick, you or somebody in your family, and know what the school is doing, because we don't have the essential tool we need. We need to be able to test everybody every day before they go to school. That is possible. It's not a pipe dream. You know, I wrote a story about Egypt recently, where the country, not a completely rich country, the country tested everybody in the country for hepatitis C. It cost 50 cents a test. Then they did a PCR test on everybody to see if the virus was really replicating. Of the 5 million people they found that had been infected, 4 million people still had active virus. That PCR test cost $5. I want you to think about comparing those prices to our prices. That's the real cost, 50 cents and $5. Some people pay $1,300 for that test. We heard those people who need those tools today. Those people are desperate to help their fellow citizens, the people they grow up with, their children. Everybody's going to be sending their kid to school blindly, and they don't need to. We're sending our kids into danger blindly, and we don't need to do that. That's a message I hope that we can get out with what we've told you today.
Well, thank you both. And stick around. We're going to head now to answer some viewer questions. We call the segment Your Safety. It's an opportunity to have your questions about daily life in the pandemic addressed by our 2 public health experts. And of course, if you'd like to send in a question to be addressed on a future program, please write to us at secondopinion@latimes.com. Dr. Soon-Shiong, a question about masks for you from Robin McGuire in Los Angeles. The question is, when is it necessary to wear a mask outside?
Look, I think it's necessary to wear a mask outside during this pandemic all the time. And specifically the type of mask that protects you and protects your fellow man. These cloth masks are protective. The N95 mask obviously is more protective. And I'm now beginning to see the evolution again, with full disclosure, working with a graphene company that's actually developing graphene as a barrier that's shown 2 logs reduction, physical reduction, embedded within the cloth. So the answer to that is we need to wear the masks not only outside all the time, because these droplets, these nano droplets and these particles actually go in this plume. Eli, let me take this opportunity to address a little bit of what we also heard and I want to really echo what Bill is saying about how this pandemic has truly unearthed the inequities in this country. If you look at the Apache Nation, you look at the Navajo Nation, you look at the Central Valley, the common denominator here of this high death is one, for example, it's even terrible in the Apache Nation and Navajo Nation, they don't even have water, they don't have lights. And I've been fighting for the last 20 years of my life to figure out how we actually address the infrastructure, where frankly I think our healthcare system has been broken because people think that insurance is actually healthcare. It's not the insurance that's going to save you, it's the outcomes. And the fact that we've been focused, our whole healthcare system has been built when we built Medicare around reimbursement. But it wasn't tied to the monitoring of the outcomes and creating this infrastructure for outcomes measurement. So I think until we build that infrastructure and rebuild this whole healthcare system, this pandemic, this question about what's going to happen in the healthcare system is not only real, it's for the first time unveiled it. Because this virus affects the heart, the muscles, the GI tract, the pancreas, the brain, this chronic fatigue syndrome. And it is when we talk about these pre-existing conditions of diabetes, hypertension, I believe all of that and obesity relates to the immune system, because those patients with those pre-existing conditions have actually an impaired immune system. This is a wake-up call, not just to the world, but more so to our country, when you look at the way we are behaving relative to the rest of the world.
Professor Haseltine, I have a question for you from Emiko in Southern California. And the question is it true that children are less likely to get infected and spread coronavirus? My concern is that once schools reopen, we will see a number of school-related cases. And obviously, this is another question that affects parents who don't have as many options disproportionately. If you have to go to work, you may not have the equipment at home to have your kid virtual learning. This is really a question that affects families in places like Imperial County, as well as all across Los Angeles.
Remember, this is a cold virus. 1/3 of the people who have a cold have a coronavirus. And in fact, most of the people who get this, who have symptoms, have a cold. How do you catch colds? You catch a cold when you send your kid to school. That should tell you all you need to know. You send your kid to school or playground, and he comes back with a cold, and he gives you, and then you give your wife or your husband, and then you give it to your grandparent, their kid's grandparents. That's how it happens. It's not a mystery with this. That's the first answer. Are children less infectable? Under the age of 5, the answer is somewhat less infectable, but that doesn't mean they're not infectable. It means it takes more contacts. That's all. And in a school, there are a lot of contacts. Once you get above the age of 10, like high school, they're just like adults. So there's no difference. So children is a broad term. You got to say under 5, but over 5, they're easily infectable like we are as adults. And they're just as likely to get sick over the age of 10 or once they're adolescents as you are when you're 25 or 45. So we're mixing a lot of different people together, but the first answer is children are infectable. That's what you should know, that's what you should remember, and that's what you should think about when you're sending your kid to school. Then there's a third answer. Are they as likely to get sick? And It is true that the younger the child, the less likely that child is going to get sick. Now, that doesn't mean that children over 5 don't get sick. It doesn't mean that children over adolescents 12 and up aren't just like adults. They are. They get just as sick. All of those high school kids that have a desperate need to be with their girlfriend or boyfriend, or to find a girlfriend or boyfriend, and are mixing around and playing sports, are just like adults getting infected and getting sick. In fact, if you look at who's in the hospital today, it's a lot of people. The bulk of infections are in the people between 20 and 60, and the bulk of the people in the hospitals are exactly that age group. Now, do young, very young children get sick? It turns out that around the age of 5 to 8 is a very sensitive time. And some kids who do get sick get the very worst of this disease. They get all the most horrible things and they end up damaged. Brain damage, lung damage, heart damage. It is tragic to see that, especially when you look at these communities in which a lot of their young children. I want to give you a number to think about. There's about 300,000 kids who've been infected, young kids. I'm talking about little kids under 10, infected in the United States. That's a lot of kids. So we're not talking doesn't happen. This is what people have to think about as they start to think about sending their kids to school. If there's a lot of virus around, they're sending them into what I would term extreme danger. I wouldn't do it. If, like in New York, there's not so much virus around, you can do it if you're convinced that those conditions are okay, if your school is doing what it should. But we know in New York, just like there's inequities in health, there's inequities in schools. And the school building that may be in Manhattan is not going to be one that's like in the North Bronx. And who is going to be at greatest risk for the highest infection? Manhattan or the North Bronx? You know the answer, the North Bronx. It's like the Central Valley or the Imperial Valley. That's sadly, but sad case, but it's true. So that's a longer answer to a short question.
Well, it's a complex situation. We appreciate the response. We appreciate everybody who sent us questions. Again, if you'd like to send us a question to be answered on a future program, we'd like to hear from you. Here's the address, secondopinion@latimes.com. Dr. Patrick Soon-Shiong and Professor William Haseltine, before we leave tonight, I wonder if I could just ask you both for closing thoughts, taking into account perhaps the moving stories that we heard from Imperial County. And as we did last time, perhaps you could also leave us with a message that's somewhat hopeful. Dr. Haseltine, can I start with you?
Sure. What's hopeful? What I'm very impressed about is how fast the world scientific community and medical community has come together. We share information like never before. You hear that there's spies here or spy there. That's nonsense. We share everything right away. Chinese share it, Europeans share it, Japanese share it, and we share it. And Patrick will be first to tell you how he shares it. So we share the information. That is absolutely fantastic. And that's the best of human nature, trying to solve a deep problem. The second thing is, as a result of all that, we're getting to grips with what this does. And you've heard all these different ideas to get it. Science is going to get this thing. We're going to wrestle it to the ground through science. But right now, we don't have those tools yet. It takes time. You have to think it through. You have to test it. You have to make sure it's safe. So we need right now to have those tools. And fortunately, they're there. You know, while we were having 60,000 people infected in one day, the Chinese had 35. 35 of a country that's 6 times bigger than ours. While we had 1,250 people die, the Chinese had none. None died. Who is doing a good job? Humans. They're human. We're human. They had the tools. We have messed up. Can we straighten ourselves out? Of course we can, with the determination. And we don't even need all these fancy tools, but we're getting them, and it's going to make our job easier. But we can beat this, and we will. We'll beat it organizationally, and we'll beat it scientifically. I'm 100% convinced. When you come back to me, maybe it's 3 years from now, maybe it's 5 years, and say, were you right? you'll say, yes, you were right. We were right. We beat it. So we can do it, but we've got to do it to save lives now. And I think that's the message you're hearing, the things we can do now.
Professor Haseltine, thank you so much. Dr. Soon-Shiong, your closing thoughts.
I'm buoyed by the fact that as I watch and work actually directly with some of the scientists and our science, that with the tools that we have in our hand today, with our supercomputing, the knowledge, the dynamic analysis that we've done with the virus, that we're now beginning for the first time truly to understand it's a tricky thing, very much like cancer. So in a very methodical way, number one, we have this rapid test today. So with just, as you said, not rocket science, rapid test, mask, social distancing, isolate, we can actually reduce this virus from being the factory. But it'll come back. This virus is here to stay. Having said that, we now understand not only how we could block it with monoclonal antibodies, how we could decoy it with what we call an ACE2 decoy, how we can vaccinate against it, how we can generate a T cell against it. All these tools I'm now beginning to touch, feel, and see. And I really believe that this is not that far away because of the collaboration. However, what I do worry about is the ability to ensure that at a global level, whether you're rich or poor, that there's enough product for everybody to participate in. I do worry about places like the Navajo Nation, the Apache Nation, the Central Valley, places in Africa. So I think what I'm hopeful is that this country can take the lead again. This is like the shot to Mars. And we really have all the tools that actually can get there. So the hopeful news is this is a war that is completely winnable.
Dr. Patrick Soon-Shiong and Professor William Haseltine, thank you again both so much for all the information and insights on this program. That does it for the second edition of the Los Angeles Times series, Second Opinion, our in-depth look at matters of health, science, and technology. I'm Eli Stokols in Washington. As we leave you with some of LA Times photographer Irfan Khan's images from California's Imperial County, we'd like to thank our guests today for bringing us the story of the people there. Until next time, take care and goodbye.